Okay, good afternoon, students. We are going to talk about the good afternoon, students. We are going to talk about the anatomy today, and today is a LMR session of anatomy. We are going to discuss about the high-yield topics in the anatomy. So, if you could share my voice and see the screen properly, type yes on the chat box. If you could share my voice and see the screen, type yes on the chat box. Okay, so we are going to start our anatomy session today. So in anatomy, the high-yield areas are going to be your abdominal pelvis, and then head and neck, and then neuroanatomy, and the part of embryology, people. But here, how are we going to do is like we are going to cover you technically the basic important steps which has been related to your uh, anatomy. So we will discuss region by region the high yield areas and the important images, and what are the things to remember, what are the things you need to master. All those things will be will be discussed in this chapter. So upcoming 2.5 session is going to be a revision session where we discuss a lot of steps and we discuss about only the important highlights in your anatomy. So this is a concise class. Don't think like this is a like a full class that you may master each and every corner of your anatomy. We will discuss only the important and the high yield areas in the anatomy. So first thing, we are going to discuss region by region. On that, the first region is going to be your upper limb. So speaking about the upper limb, the first area of interest is your bones of upper limb. So bones of upper limb, we are going to talk about the clavicle. So what are the bones of upper limb? We are having a clavicle, scapula, humerus, radius, ulna, and carpal bones, metacarpal bones, and phalanges. Yes or no? Now we are going to discuss about what are the important highlights of your clavicle. So speaking about the clavicle is a long bone which lies horizontally in your body. So the only long bone which lies horizontally in your body is your clavicle, and then you have the this what do we call it? We are having this clavicle is a only bone which has an intramembranous ossification. Clavicle is a only bone which has an intramembranous ossification. So what are the two peculiarities of your clavicle, people? We are having two things. So can you able to see the screen properly? Can you able to see the screen properly? Yes or no? If you can able to see the screen properly, type yes on the chat box, people. If you could hear my voice and see the screen properly, type yes on the chat box. If you could hear my voice and see the screen properly, type yes on the chat box. On whomsoever is present to type faster, that if you could hear my voice and see the screen properly, type yes on the chat box. Okay, now speaking about the clavicle is the only long bone which lies horizontally, people. And clavicle is the only bone which possesses the intramembranous ossification. So only long bone which lies horizontally, and only bone with intramembranous ossification. That means it does not have any medullary cavity. Okay, that does not mean it does not have any medullary cavity. And the clavicle is the first bone to start ossifying your body. And the weakest point of the clavicle is junction between medial 2/3 and lateral 1/3. And the clavicular fracture may occur whenever there is a fall of outstretched hand. So what are the things you have to know about the clavicle? Long bone which lies horizontally, intramembranous ossification, absence of medullary cavity, first bone to ossify in the body, weakest pointers. Type faster, people. What is the weakest point of clavicle? The junction between medial 2/3 and lateral 1/3. Junction between medial 2/3 and lateral 1/3. And a clavicular fracture mostly occurs when there is a fall in outstretched hand. So they may give you the question with the fall of outstretched hand. You may also suspect there is a fracture of your clavicle. There is a fracture of your clavicle. And then you are having a scapula. So scapula is nothing just but your shoulder blade. And your scapula contains a few important anatomical landmarks. For example, like we are drawing a scapula here. So we are drawing a scapula here with the glenoid cavity and with the superior angle and the inferior angle, all those things. And here is your suprascapular notch. Suprascapular notch, where you see adjust my scapula. This is your glenoid labrum, and this is your, rather draw it a little bit neatly. Okay. Consider this is your glenoid labrum, and this is your suprascapular notch. This is your suprascapular notch. This is your suprascapular notch. Suprascapular notch is the structure where you see your suprascapular nerve passing through. What is the structure which is passing through the suprascapular notch? Suprascapular nerve. The name itself stands. Okay. Whatever the name of the anatomical structure, the name of the nerve will passes. Okay. And then you have the spine of scapula. And then you have the spine of scapula. And end of the spine of scapula, you see the acromion process. And then you see there is one more bony projection called as coracoid process. One more where you see the bony process called as coracoid process. So we have the spine here, and we have the acromion process here. And then we have the coracoid process here. Coracoid process here. And then we have the glenoid cavity here. Since it is on the posterior aspect, the spine is present on the posterior aspect. So we draw the posterior aspect. So posterior aspect, lateral side, we have a glenoid cavity, and posteriorly we have the spine, which ends as acromion process. And then you have the coracoid process, and then you have the suprascapular notch, where you see the suprascapular foramen, which is passing through it. And then you have this acromion process. Along with the acromion process, you see acromion process and the spine of scapula. You see the muscle called as deltoid. You see the muscle called as deltoid, which is passing through it. Deltoid, which is passing through it. And then you have one more muscle which is attaching to the spine of scapula, which is your trapezius. I draw it here, but in the inferior aspect, you may see the trapezius. And lateral side, you may see the deltoid here. Okay, lateral side, you may see the deltoid here. And apart from that, you have this coracoid process. This coracoid process gives rise to three important muscular attachment, people. What are they? This coracoid process gives rise to three important muscle attachment. One is your short head of biceps. One is your short head of biceps. Short head of biceps. Pectoralis minor. Pectoralis minor. And then you have this coracobrachialis. So name itself says coracobrachialis. So coracoid process gives rise to three important muscular attachment. One is your short head of biceps, pectoralis minor, and coracobrachialis. So since it is a short head of biceps which has been attached on the coracoid process, where do you see the attachment of your long head of biceps? So you have here two important anatomical landmarks. One is your supraglenoid tubercle and infraglenoid tubercle. One is your supraglenoid tubercle and infraglenoid tubercle, where you see the attachment of long head of biceps on supraglenoid tubercle, long head of biceps and supraglenoid tubercle, and long head of triceps on infraglenoid tubercle. Long head of triceps on infraglenoid tubercle. So these are the muscular attachment of your scapula that you have to remember, people. So scapula is nothing, just the shoulder blade, and the scapula is having a variety of important anatomical landmarks and your attachment. So one is your suprascapular notch, where you see the what nerve passing through, people? What nerve is passing through the suprascapular notch? Type faster. What nerve is passing through the suprascapular notch? Type faster, faster. What nerve is passing through the suprascapular notch? Suprascapular nerve. And what nerve is passing through the tip of the, what muscle attached to the coracoid process? You see the short head of biceps, pectoralis minor, and coracobrachialis. Short head of biceps, pectoralis minor, and coracobrachialis. And then you have this acromion process where you see the deltoid fibers, and in the spine of scapula, you see the trapezius and the deltoid attachment. And then you have a glenoid cavity and a supraglenoid and infraglenoid tubercle, where you see the attachment of your long head of biceps and triceps. Biceps and triceps. So this is all about your scapula, people. So what are the important things you have to remember in clavicle? Only long bone, which lies horizontally, and long bone with intramembranous ossification, and long bone, which contains the absence of medullary cavity, and it is the first bone to ossify in your body, and weakest point of clavicle is junction between your medial 2/3 and lateral 1/3. And the scapula, we had as important anatomical landmarks and their attachments we have seen. Speaking about the important anatomical landmarks and attachments, suprascapular knots, where you see the attachment of what muscle? Sorry, what structure will pass through the suprascapular notch? What is the structure which pass through the suprascapular knots? That is your suprascapular nerve. And what is the muscles which attaches to your coracoid process? One is your short head of biceps, another one is your pectoralis minor, and another one is your coracobrachialis. And then you have this acromion process of scapula, where you see the deltoid attachment. And apart from that, you have a supraglenoid and infraglenoid tubercle, where you may see the attachment of long head of biceps and long head of triceps. So in the old age, your suprascapular notch will convert into suprascapular foramen. So then we are going to the third bone called as humerus. Speaking about the humerus, the weakest point of your humerus is your surgical neck. Let me draw the humerus here, people. Let me draw the humerus here. Forgive me for not drawing properly. Forgive me for not drawing properly. Okay, consider a rough diagram of humerus. So you are having a head here. Behind the head, you have this anatomical neck, and behind the anatomical neck, you have the surgical neck. Anatomical neck. And behind the anatomical neck, you have the surgical neck. So speaking about the humerus, the carrying angle of your humerus is 163 degree. So the carrying angle is 163 degree, which is so called as carrying angle. Okay. Now, what is very, very important in the case of your humerus? Humerus contains a variety of structure, but what are the important things to know in terms of humerus? So the important things you have to know in terms of humerus is the fracture site and the nerves which has been injured during the fracture site. So first one is your surgical neck. So speaking about the surgical neck, the fracture, I will redraw this image with all the landmarks has been eliminated. So I'd rather draw it here. I'll rather draw the humerus. Okay, consider the fracture occurs at the surgical neck. surgical neck will cause injury to what now, people? Fracture occurs at the surgical neck will cause injury to. Surgical neck will cause injury to what now, people? Fracture occurs at the surgical neck will cause injury to axillary nerve. You should remember that as axillary nerve. And after axillary nerve, you have the shaft of the humeral fracture. If the shaft has been broken, fracture on the shaft will give rise to the injury to radial nerve. Radial nerve will get injured. I rather write it as heading up injured nerve, which is a radial nerve. Fracture on the shaft will injure the radial nerve, and the fracture on the medial epicondyle. Will give rise to fracture on medial epicondyle. Will give rise to ulnar nerve. And fracture on the supracondylar region. Here comes a problem, or like you have to know the important things. Fracture on the supracondylar region, there will be two possible options that may be given in the FMGE. I will write both, and I will also give you which one you have to prefer if they given a both. So the most preferable answer is anterior interosseous nerve. Over the median nerve. So if there is a median nerve, choose median nerve. If there is an anterior interosseous nerve, choose the anterior interosseous nerve. But if they give you both, the preferable option you have to choose here is anterior interosseous nerve over the median nerve, people. Okay, so this is all about the humerus. You have to know what is the weakest point of humerus. Everybody faster. What is the weakest point of humerus? What is the weakest point of humerus? Which is the surgical neck. Very good. And what is this fracture occurs at the surgical neck will cause injury to what nerve? Fracture occurs at the surgical neck will cause injury to what nerve, people? Type faster. Injury to what nerve? Axillary nerve. While the fracture occurs at the shaft of the humerus will lead to radial nerve, and the medial epicondyle would lead to ulnar, and the supracondylar fracture could lead to anterior interosseous nerve. Okay, this is all about the humerus, people. Now we talk about the radius. So speaking about the radius, we are having only the clinical part, which is very, very important. So in the clinical part, we are having a Colles fracture, we are having a Smith fracture, and we are having a nursemaid elbow. Okay, Colles, Smith, and nursemaid elbow. So what is a Colles fracture? Fracture on the distal segment of your radius. Okay, fracture of the distal radius will cause a Colles fracture. Consider your hand is like this. With all the carpal bones and metacarpal bones which has been there. Now here, when someone hit you, and you have the radius which has been present here, will just get cracks over here. Okay, consider this is your radius and the fracture is happening here. And when the fracture is happening here, there is a distal segment which is present here. Yes or no? Yes or no, people? When the fracture is happening, you have the two segments. One is your proximal segment and the one is your distal segment. Yes or no? If the distal segment is upward and backward, then we used to call that as, so see, there is a fracture which has been happened here, And you have the proximal and distal segment. The distal segment was upward and backward. Upward and backward. Well, if it is a upward and backward, then it is a Colles fracture, where you may see dinner fork deformity, people. Dinner fork deformity, where your hands look like a dinner fork. Because when the patient is having a Colles fracture, the distal segment will move upward and backward. And when it moves upward and backward, you may see the fracture of the where the distal fragment of the radius will be popping up, and that in turn will make your hand looks like a dinner fork. Okay, that's why we used to see the dinner fork deformity is seen in Colles fracture. Very, very important MCQ. Dinner fork deformity is seen in Colles fracture. Rather write it as positive. Dinner fork deformity is seen in Colles fracture. And reversal of Colles fracture is Smith fracture. So in Smith fracture, the proximal fragment will remain same, while the distal segment will be inward and downwards. Inwards and downwards, then it is so called as Smith fracture. So outward and upward is so called as your Colles fracture. Inward and downward is so called as your Smith fracture. Downward and inward is so called as your Smith fracture, which is also called as a reversal of Colles fracture. Reversal of Colles fracture. Colles fracture. Okay. Now you have this nursemaid elbow. Next condition is an important condition about the radius you have to know is your nursemaid elbow. Speaking about the nursemaid elbow, you have the radial head subluxation when the child is lifted by the wrist. When the child is lifted by the wrist. So you have the like a babysitter. You have the babysitter who holds their hands along with the child, and the child hands has been pulled upward. So if you pull this child in the upward direction, then there will be a radial head subluxation. Radial head subluxation from your elbow joint. Okay. So that in turn causes an annular ligament tear. That in turn causes an annular ligament tear. Annular ligament tear. So you may see the nursemaid elbow where you see the tear of annular ligament. Where you may see the tear of annular ligament. Okay, nursemaid elbow. Radial head subluxation, annular ligament tear will cause a nursemaid elbow. And apart from that, you have the Galeazzi fracture. So speaking about the Galeazzi fracture, you have a distal radioulnar joint dislocation with the fracture of your lower radius, which we have it in your test, which we have it in our text. So Galeazzi fracture is radial distal joint liquation with the fracture of your lower radius. And what part of radius it's attached to, what structure? This is kind of like low yield, people. So you can move it as it is. So head is attached with the capitulum and the radial notch of ulna, while the radial tuberosity attaches with the bicep brachii, and styloid process will attach with the brachioradialis, and distal end is attached with the proximal row of your carpal bones, except your pisiform bone. So this is all about the radius you have to know. So radius, we are having a 4 important clinical condition. Galeazzi fracture, which is a fracture of your distal radioulnar joint, fracture of your distal radius along with the dislocation of your distal radioulnar joint. That is your Galeazzi fracture. Okay, and then you have this nursemaid elbow, radial head subluxation along with the annular ligament tear is so called as nursemaid elbow. And then you have the Colles fracture, people. Colles fracture is a fracture of the radius, while the distal fragment of the radius will be upward and outward. You may also see what type of deformity in the Colles fracture, people. You may also see what type of deformity is in the Colles fracture. Type faster, what type of fractures you may see it in the, what type of deformity you may see it in the Colles fracture. That is your dinner fork deformity. Okay, that is your dinner fork deformity. And reversal of Colles fracture is so called as Smith fracture. Reversal of Colles fracture is so called as Smith fracture. We used to remember the first letters at C and S. C and S sound similar but different and opposite. C and S sound similar but different and opposite. We used to remember in this way. Colles fracture, distal radius with posterior displacement of your radius. Smith fracture, reversal of Colles, where you may see the proximal displacement of your radius. Okay, then you are going for ulna people. Speaking about the ulna, we are having a Monteggia fracture. So Monteggia fracture is nothing just the upper ulnar fracture with radial head dislocation. Upper ulnar fracture with radial head dislocation is your Monteggia fracture, while lower radius fracture will cause us a distal radial ulnar joint dislocation is so called as Galeazzi fracture. Okay, Galeazzi fracture. And then you have the student elbow. Student elbow, speaking about the student elbow, inflammation of your olecranon bursa is your student elbow. And apart from that, you have the ulna, three areas, articulates with the three structures. Head, radius forms the inferior radioulnar joint. Ulnar tuberosity forms insertion of brachialis. And olecranon process gives rise to the attachment to triceps tendon. Triceps tendon. So student elbow, Monteggia fracture are the two important things you have to remember. Inflammation of olecranon bursa is student elbow. And upper ulnar fracture with the radial head dislocation is Monteggia fracture. Distal radioulnar joint dislocation with the fracture of the lower radius is Galeazzi fracture. And you have the fracture of your distal radius with the distal segment moving upward and outward, Colles fracture. Dinner fork deformity is seen in Colles fracture. Reversal of Colles fracture is Smith fracture. And attachment, the suprascapular nerve passes through suprascapular notch. Suprascapular notch. Carrying angle of your what do we call it? Carrying angle of your humerus is 163. Fracture occurs at the shaft of the humerus, will lead to what nerve injury? Radial nerve injury. And apart from that, we are having a metacarpal and a carpal bone. Sorry, carpal and metacarpal bones. So speaking about the carpal bones, everybody know that there is a there is a thing called as a proximal row and a distal row, and there is a mnemonic we used to have it for them. What does that? She looks too pretty, try to catch her. Yes or no? She looks too pretty, try to catch her. So where we see the scaphoid, lunate, triquetrum, pisiform, trapezium, trapezoid, capitate, and hamate. Trapezium, trapezoid, capitate, and hamate. And out of this trapezium, trapezoid, capitate, and hamate, we have to talk about a few important things here, people. There are a few important FMGE highlights on the carpal bones, which has been given here. What is the most common fractured carpal bone? Which is a scaphoid bone. And most common displaced bone, carpal bones, it is your lunate bone. And then you have this triquetrum, which is a pyramid shape, and you have this pisiform, which is a P-shaped one. And apart from that, you have the important highlights is which one is the first to ossify, which is your capitate. Capitate is a one where you see the first to ossification. First ossification is seen in capitate, while last to ossify is your pisiform. First to ossify is your capitate. First to ossify is your capitate, while last to ossify is your pisiform. Last to ossify is your pisiform. So we are having this capitate and pisiform. Capitate is first to ossify, and it is also a largest carpal bone. And the pisiform is a P-shaped bone, which is the last to ossify. Okay, and then you have this hamate. Hamate is the one where you see the wedge-shaped bone with a hook. And hamate is the bone which takes 2 years for ossification. Okay, 2 years for ossification. Then you are having this metacarpal bone. So they are 5 in number, and the fracture of first metacarpal boxes. Fracture of fifth metacarpal is boxes. Here comes, there is a small twist in the MCQs, people. One time in FMGE, the improper wearing of boxing gloves could result in the fracture of what metacarpal they had asked. So you have to remember two things, people. One is which one is making you, what type of boxers will get what type of fracture of metacarpal bone. A proper boxer will get the punches, who gives the punches will get the fracture on the second and third metacarpal, while the improper boxer or the untrained boxer who don't know how to wear gloves will get the fracture at the fifth metacarpal bone. So the proper one will get the boxer's fractures around the, first, second, and third metacarpal bone, while the improper boxer or improper wearing of gloves could damage fifth metacarpal bone. So don't go directly with the words of boxers and don't get easily influenced. So you have to know improper wearing of the glove could result in fifth metacarpal neck, while the proper wearing of gloves and is a boxer and got a fracture, that will be the body of your second and third metacarpal bone. And first metacarpal base fracture is your Bennett's fracture, okay, which is your Bennett's fracture. So these are the bones of your upper limb, people. Then we're going to talk about your joints of your upper limb. Speaking about the joints of your upper limb, what type of joint and what is the joints which are present in the upper limb and what type of joint it is pretty important question, which has been asked several times in FMGEs too, previous FMGEs too. So if they want to test you, your musculoskeletal system is good or not, then they may ask you this. So what type of joint is your sternoclavicular joint? Saddle joint. Pretty mug up, straight mug up, where you don't need to, you have no other concepts to keep that in mind. You have to mug up, pretty straight mug up, people. So sternoclavicular joint, saddle joint. Shoulder joint, which is a ball and socket joint. Elbow joint, which is a hinge joint. And radio-ulnar joint, superior and inferior, both are pivot joint. And middle radio-ulnar joint is so-called a syndesmosis because we have the membrane which is connecting together. And syndesmosis is your middle radio-ulnar joint. And apart from that, you have the wrist joint, which is your ellipsoidal one. And apart from that, you have the carpometacarpal, saddle joint, metacarpophalangeal, ellipsoid joint, and interphalangeal is hinge joint. Okay, interphalangeal, which is a hinge joint. Clear? Clear, everybody? So you're having a sternoclavicular joint. So sternoclavicular joint is your saddle joint. So let me put up to your upper limb joints. So consider like this is your clavicle. Consider like this is your clavicle and this is your scapula. And your scapula is articulating with the humerus. And then your humerus with the radius and the ulna. Your humerus with the radius and the ulna. Radius and ulna, and radius and ulna with the carpal bones. And your carpal bones will be attached with the metacarpal. And your metacarpal will be attached with the phalanges. Your metacarpal will be attached with the phalanges. Rather draw it in this way. Carpal bones will be attached with the metacarpals, and your metacarpals will be attached with the phalanges. So consider these are the things. So shoulder joint. So the first thing is your shoulder joint. Speaking about the shoulder joint, what type of joint is your shoulder joint? That is your ball and socket joint. Okay. In our notes, we also given a sternoclavicular joint. So speaking about the sternoclavicular joint, which attaches with the manubrium of sternum. So the sternoclavicular joint is the saddle joint, while shoulder joint is the sternoclavicular joint is a saddle joint, while the shoulder joint is a ball and socket joint. And then we have this elbow joint. Elbow joint is a hinge joint. And you have this radio-ulnar joint. speaking about this radio ulnar joint, we are having a 3 types of radio ulnar joint. One is your superior and inferior radio ulnar joint, or ellipsoidal joint, Let me write it here. Or ellipsoidal joint, while your middle radio ulnar joint is so called as syndesmosis. So you have to remember that syndesmosis is your medial radio ulnar joint, or middle radio ulnar joint, middle radio ulnar joint. And then you have this proximal bones. So speaking about that, you are having this wrist joint here. So wrist joint is also an ellipsoidal joint. Ellipsoidal joint is your wrist joint, and then between your carpal and the metacarpal bones, you have this carpo-metacarpal joints, and which is your saddle joint. And below the carpo-metacarpal joint, you have the metacarpophalangeal joint, which is your ellipsoidal joint. And then you have this interphalangeal joints, which is a hinge joint. So I give you all the joints, you have to match them. Okay, I'll tell you the joints, you have to match them with the, let me do the portion here. Put you the zoom in of the table here, where I'm gonna tell you the next part and you're gonna name it the exact one. What type of joint is your ball and socket joint? What type of joint is your ball and socket joint? What type of joint is your ball and socket joint? Which is your shoulder joint. So here you may have the list of joints. I'm gonna tell you the names. You're gonna tell me which joint belongs to that type. Okay, next is a syndesmosis. What type of joint? What type of joint? Okay, you got the screen here. And zooming in is not going in further. So we will do that in the next session. No problem. So sternoclavicular joint, saddle joint. Sternoclavicular joint is your saddle joint, and the shoulder joint is your ball and socket. Elbow joint is your hinge joint. Radio ulnar joint, superior and inferior, is pivot joint, and middle radio ulnar joint is syndesmosis. Wrist joint is your ellipsoidal. Carpo-metacarpal joint is saddle joint. Metacarpophalangeal is ellipsoidal. Interphalangeal is hinge joint. Okay, and then you have this muscle highlights. So what are your rotator cuff muscles? So the rotator cuff muscles are your sits minor. I used to remember it as a sits minor, SITS minor. So what is sits minor? Subscapularis, infraspinatus, teres minor, and supraspinatus. Subscapularis, infraspinatus, supraspinatus, and you have the teres minor. That's why I used to remember it like the minor sets. Okay, the minor sets. Okay, and apart from that, there is the initiation of your shoulder abduction are pretty important. 0 to 15 degree is mediated by your supraspinatus, and 15 to 90 degree is maintained by your deltoid. 15 to 90 degree is maintained by your deltoid, and then more than 90 degree is maintained by your serratus anterior. More than 90 degree is done by your serratus anterior, okay, which is supplied by your long thoracic nerve of Bell. Okay, if a patient where there is an absence of a sternal portion of your pectoralis major and minor muscle, a patient with the absence of your sternal portion of your pectoralis minor and major is seen in Poland syndrome. Very, very important MCQ. Another important MCQ, any patient with the absence of sternal portion of your pectoralis major and minor, which is seen in what syndrome? Poland syndrome. Which is seen in what syndrome? Poland syndrome. So these are the pictures. Sometimes they may ask you like what type of muscle it is, and they may ask you like identify the image X and Y on the given, identify X and Y on the given image. They may ask you as a question. So that's why we are given you the picture-based question of your picture of your rotator cuff muscles, where you guys have to remember like a sits minor. Okay, supraspinatus, infraspinatus, teres minor, and subscapularis and subscapular. So this is all about the bones, joints, and muscles of your upper limb. Now we are going to talk about the very, very important portion of your upper limb. Shall we move on to the important portion of your upper limb, people? Shall we move on to the important portion of your upper limb? The important portion of your upper limb is your brachial plexus, people. The important portion is your brachial plexus. So what are your brachial plexus? So here we have the image of your brachial plexus. So back to what are the roots of your brachial plexus? The brachial plexus originates from the ventral rami of the brachial plexus originates from the ventral rami of C5 to T1. Ventral rami of C5 to T1. C5, C6, C7, C8, and T1. C5 to T1. Sometimes C4 will be added. Sometimes T2 will be added. So C5 to T1 is the one where you may see the most of the patient, the origin or roots of your brachial plexus. So the roots of your brachial plexus could be C5, C8, C6, C5, C5, C6, C7, C8, T1, and sometimes T2, and sometimes C4. So ventral rami of C5 to T1 will be over here. So on that gives rise to all four nerves. On that all four nerves, so here is a vertebral column. So here is a vertebral column. So here is the spinal nerves, which has been emerging out, which has been highlighted in the yellow color. C5, C6, C7, C8, and T1. Okay, so the ventral rami of C5 to T1 forms a roots of your brachial plexus. Sometimes it may give attachment to C4 and T2. So the C5 and the C6 root will combine to form a upper trunk, people. C5 and the C6 root will combine to form a upper trunk, and this upper trunk will gives rise to this upper trunk will be formed from the nerve roots of C5 and C6, and then you have this middle trunk which is formed from C7, and then you have this lower trunk or inferior trunk which has been formed from C8 and T1. C8 and T1. Okay, so from the roots you have the trunk, and from the roots you may also have some small branches. What are the small branches which is arising from the root? One is your dorsal scapular nerve, which is your C5. Another one is your long thoracic nerve, which is your C5, C6, C7. Another one is your long thoracic nerve, which is your C5, C6, and C7. Okay, this long thoracic nerve will supply your serratus anterior. So long thoracic nerve injury could causes paralysis of your serratus anterior muscle, which in turn cannot able to produce abduction over 90 degree. So the patient may experience a winging of scapula in the long thoracic nerve injury, which gets origin from C5, C6, C7. Clear, people, about your roots? So the roots gives rise to 3 trunks and 2 branches. What are the 3 trunks and what are the 2 branches? What are the 3 trunks and what are the 2 branches? What are the 3 trunks and what are the 2 branches you have to know? What are the 3 trunks and what are the 2 branches? So the 3 trunks are your upper trunk, middle trunk, and lower trunk, which is coming from your C5 and the C6 gives rise to upper trunk, while C7 gives rise to middle trunk, and the C8 and the T1 gives rise to lower trunk. So apart from that, it gives rise to 2 branches. One is your dorsal scapular nerve, which are arising from your C5, and another one is your long thoracic nerve, which arises from your, one is your dorsal scapular nerve, which arises from your C5. Another one is your long thoracic nerve, which arises from your C5, C6, C7. Long thoracic nerve, which is arising from your C5, C6. and C7. Then you have the upper trunk, middle trunk, and lower trunk. Upper trunk injury could result in the Erb's palsy, where you may see the policeman tip deformity or waiter's tip deformity. And then you have the lower tongue injury, where you see the Klumpke's palsy, where you see the loss of function of your wrist and hand, which is similar to that of your Horner syndrome. And apart from that, you have the two branches coming from the upper trunk. One is your nerve to subclavius, which is your C5 and C6. Here, I highlighted in the green people, C5 and C6, which is coming from your nerve to subclavius, which is coming from your upper trunk. And then you have the suprascapular nerve, which is also coming from your upper trunk. So roots 2 branches, upper trunk 2 branches, while the middle and inferior trunk or middle and lower trunk will not give rise to any branches. So the roots gives rise to 2 branches. What are they? One is your dorsal scapular nerve, another one is your long thoracic nerve. While the upper trunk gives rise to 2 branches. What are they? Nerve to subclavius, another one is your suprascapular nerve. Nerve to subclavius and suprascapular nerve. And then you have this trunks which gives rise to anterior and posterior divisions. So the anterior division of your upper 2 trunk, which is your upper and middle trunk, gives rise to lateral cord, while the middle anterior division of your lower trunk gives rise to your medial cord, and your posterior division of upper, middle, and lower trunk gives rise to posterior cord. So you have the 3 cords which is arising from the 3 trunk, which is arising from the 6 divisions actually. So roots to trunks to division, anterior and posterior division. So anterior division of your upper and middle trunk gives rise to lateral cord, while anterior division of your lower trunk gives rise to medial cord, while the posterior division of your upper, middle, and lower trunk gives rise to posterior cord. And each one gives rise to the variety of branches, people. Each one gives rise to the variety of branches. So the medial cord and the lateral cord, we discuss about the branches. Here we have mentioned only the important branches. So speaking about the lateral cord, it gives rise to the musculocutaneous nerve and lateral half of median nerve. While your medial cord gives rise to, here you may have this musculocutaneous nerve, which is C5, C6, and the C7. Musculocutaneous nerve, which is your C5, C6, and the C7. And then you have this medial half of median nerve. Which is giving rise to one half is derived from lateral cord, and another half is derived from medial cord, and both can combine and gives rise to median nerve, where you may have the nerve root of C6, C7, C8, and T1. And your posterior and median cord will also gives rise to another branch called as ulnar nerve. While the posterior cord, it gives rise to radial nerve and axillary nerve. So you're having a 3 cords, which gives rise to 5 important branches, and the rest of them are smaller branches. So what are the 5 important branches that this 3 cords gives rise to? One is your musculocutaneous nerve and lateral half of median nerve by your lateral cord, and median half of median nerve and your ulnar nerve by your medial cord, and axillary nerve and your radial nerve by your posterior cord. Posterior cord, yes. So you have this axillary nerve root is C5, C6, radial nerve root is C5, C6, C7, and C8 and T1. So that's why radial nerve is also a thickest nerve of brachial plexus. So why the radial nerve is so called as the thickest nerve of brachial plexus? Because it takes the origin from the entire brachial plexus from C5 to T1. It takes the origin from the entire brachial plexus, such as C5 to T1. So that's why it is so called as the thickest nerve of brachial plexus. Okay. So this is all about the brachial plexus. So what are the roots? Anterior rami of C5 to T1, sometimes C4 and T2. And what are the branches from the roots? 2 branches. What are they, people? One is your dorsal scapular, another one is your long thoracic nerve. Okay, then the roots will give rise to trunk. What are the trunk? Upper trunk, middle trunk, lower trunk. Upper trunk comes from C5, C6, middle trunk comes from C7, lower trunk comes from C8 and T. Can everybody able to hear my voice? Can everybody able to hear my voice? If so, type yes on the chat box. We had a technical glitch. Very sorry for that. We had a small technical glitch. Very sorry for that. If you could hear my voice and see the screen properly, type yes on the chat box. If you could hear my voice, hello, bro கேக்குதா? இது என்ன ப்ரோ, இது ஐபேட் ஆஃப் ஆயிடுச்சு. So sorry, we had a technical glitch. Is everybody here? Is everybody here? If you could hear my voice and see the screen properly, type yes on the chat box. If you could hear my voice and see the screen properly, type yes on the chat box. We had a technical glitch, so sorry for that. So if you could hear my voice and see the screen, type yes on the chat box. We had a technical glitch. And if you could hear my voice and see the screen properly, type yes on the chat box. Can you able to see the screen, people? Can you able to see the screen properly? Can you able to see the screen properly? Can you guys able to see the screen properly? Yes, if so, type yes on the chat box. Okay, much better. Shall we proceed, people? Shall we proceed? Okay, so speaking about the brachial plexus, so brachial plexus are giving rise to the roots of C5 to T1, which is the anterior rami of C5 to T1. Okay, and the roots of C5 and the C6 will combine to form upper trunk, and C7 will continues as a C7 will continues as a middle trunk. C8 and T1 will be continuing as a inferior trunk. Before giving rise to the trunks, it gives rise to two branches. What are the branches which is arising from root? One is your dorsal scapular nerve. Another one is your long thoracic nerve. Dorsal scapular nerve and long thoracic nerve. And then you have the superior or upper trunk, which gives rise to two branches. One is your nerve to subclavius, another one is your suprascapular nerve. Another one is your suprascapular nerve. And apart from that, the trunks gives rise to divisions, anterior and posterior divisions. And the anterior divisions of the upper two trunks gives rise to lateral cord, while the anterior division of the lower trunk gives rise to medial cord, and all the posterior divisions gives rise to the posterior cord, and all the three posterior division gives rise to the posterior cord. The lateral cord gives rise to musculocutaneous nerve, which is a nerve root of C5, C6 and C7, which is a nerve root of C5, C6 and C7. And then you have this lateral half of your median nerve, and then the medial cord gives rise to medial half of the median nerve, and and then you have this ulnar nerve. And then after the ulnar nerve, you have the posterior cord, which gives rise to two branches, important branches. One is your axillary nerve, another one is your radial nerve. And radial nerve has a nerve root of C5 to T1, which is the thickest nerve of your brachial plexus. So we can say like dorsal scapular nerve, the nerve root is C5, and then you have the long thoracic nerve, which is C5, C6, and the C7. And then you have this, apart from that, you have this nerve, two branches from the upper trunk, which is your nerve to subclavius and the suprascapular nerve. So the nerve to subclavius nerve root is C5 and the C6, and suprascapular nerve, the nerve root is C5 and the C6. And then you have the, apart from that, you have the medial and lateral cord. Lateral cord gives rise to your musculocutaneous nerve, lateral half of median nerve, and apart from that, apart from that, you have this medial cord, which gives rise to ulnar nerve. Musculocutaneous nerve, the nerve root is a C5, C6, C7, and the median nerve, it combines the upper and middle trunk. And ulnar nerve, the nerve root is, what is the nerve root for ulnar nerve, people? What is the nerve root for ulnar nerve? Faster. What is the nerve root for ulnar nerve? Faster. It is a C8 and a T1. Ulnar nerve root is C8 and T1. And apart from that, you have the small minor branches like a pectoral nerve, cutaneous nerve of arm, and the cutaneous nerve of forearm, and blah, blah, blah. And you have the posterior cord gives rise to two important nerve, which is your radial nerve and axillary nerve. Axillary nerve, the nerve root is C5, C6, while the median nerve, so radial nerve, the nerve root is C5 to T1. Okay, C5 to T1. Okay, so far these are the important one, people. So I will tell you the nerve. You have to say me the nerve roots. So musculocutaneous nerve, it's C5, C6, C7. While the axillary nerve, it is C5 and C6. While the radial nerve, which is C5, C6, C7, C8, and T1. And median nerve, which is C5, C6, C7, C8, and T1. Okay, and then you have the lower long thoracic nerve of bell, which is your C5, C6, C7, and then you have your ulnar nerve, which is your C8 and a T1, sometimes C7, C8, and a T1, sometimes C7, C8, and T1. So these are the important nerves of your brachial plexus. These are the important nerves of your brachial plexus, and apart from that, you have to know about the important deformity you have to know on each of this nerve injury. So long thoracic nerve, you have a push against the wall. When the patient is pushing against the wall, it causes a winging of scapula, people. It causes a winging of scapula. So speaking about the long thoracic nerve, mostly the injury is occurring due to the mastectomy or stab wound, and then the test will be pushing against the wall, and you see the protrusion of scapula posteriorly. Okay, posterior protrusion of scapula. Okay, no problem. Second one is axillary nerve. Axillary nerve is the one which is due to the surgical neck of the humerus fracture, or maybe the anterior dislocation of shoulder joint. You may see the axillary nerve injury. And the test is to abduct the arm and to horizontal and ask the patient to hold the position against the downward pull. Okay. And radial nerve, you see the wrist drop in the radial nerve. And median nerve, you see the ape arm deformity or ape thumb deformity. And median nerve at the wrist cannot able to make an O with the thumb and index finger. And ulnar nerve at the elbow, you may see the claw hand. Ulnar nerve at the wrist, you may see the cannot able to hold the paper between middle and the ring fingers. And these are the important nerve injuries, people. So brachial plexus and nerve injuries we have discussed. Claw hand, ulnar nerve. Wrist drop, radial nerve. Ape thumb, median nerve. Okay, cannot make a O with the little finger. That is your median nerve at the wrist. That is your median nerve at the wrist. And apart from that, cannot be able to hold the card between your cannot able to hold the card between your middle and the ring finger, which is your ulnar nerve at the wrist. Which is your ulnar nerve at the wrist. Okay, this is all about the nerve plexus. And apart from that, you have the arteries of upper limb. So arteries of upper limb. So from the subclavian artery, you have this axillary artery. From the subclavian artery, you have this axillary artery. And then from the axillary artery, you have this brachial artery. Brachial artery splits into radial and ulnar artery. And radial and ulnar artery forms a superficial and a deep palmar arch. Superficial and deep palmar arch. Okay, subclavian artery. Subclavian artery gives rise to your suprascapular artery and superficial cervical artery. And apart from that, you have an axillary artery, which is from the first part, second part, and third part. So from the first part, it may give rise to the superior thoracic artery or highest thoracic artery. And the second part, it gives rise to thoracoacromial artery and lateral thoracic artery. And then the third part, it gives rise to subscapular artery, anterior circumflex, and the posterior circumflex humeral artery. So I used to remember the axillary artery branches at sometimes life seems a pain. Sometimes life seems a pain. seems a pain. So STLSAT. S stands for superior thoracic artery or highest thoracic artery. T stands for thoracoacromial artery. L stands for lateral thoracic artery. S stands for suprascapular artery. A stands for anterior, and P stands for posterior circumflex humeral artery. And posterior circumflex humeral artery are the arteries which may run on this area. Okay, apart from that, you have the brachial artery, and brachial artery gives rise to the largest branch, profunda brachiae artery, and then it may give rise to superior and inferior ulnar collateral artery. Okay, then you have the ulnar and radial artery. The radial artery gives rise to the recurrent branches, while the ulnar artery also gives rise to the recurrent branches, and then it also gives rise to the muscular branches. Then you have the superficial and deep palmar arch. Superficial and deep palmar arch. Superficial palmar arch is a continuation of ulnar artery, while the deep palmar arch is a continuation of your radial artery. Okay, continuation of your radial artery. While the veins of upper limb, it could be either a deep veins or a superficial vein. Superficial veins are your cephalic vein and basilic vein and medial cubital vein. And while the deep veins are axillary, subclavius, brachial, and then radial and ulnar veins. So the arteries follows the venous course, the veins follows the arterial course, where you may see the radial and the ulnar like a veins which may combine with the brachial vein, and the brachial vein to axillary, axillary to subclavian, axillary to subclavian. That's why they used to call that as a venous committant. We used to call that as venous committance, people. Then apart from that, we are moving on to the lower limb. So far we have done about the upper limb. So the upper limb ones, the important ones we have done. So we will revise it for 5 minutes, and then we go. First bone to ossify in the body, first carpal bone to ossify is your capitate. First to ossify is your clavicle. And last carpal bone to ossify is your pisiform. And metacarpal bones are 5 in number. Bennett's fracture is a fracture of first metacarpal, and while the Boxer's fracture is a 5th metacarpal one. Okay, apart from that, most common fracture carpal bone is your scaphoid. Monteggia fracture is a fracture of upper ulna. Galeazzi fracture is a fracture of your distal radius along with the distal radio-ulnar joint. And you have the Colles fracture, posterior displacement of radius. And you have the Smith fracture, anterior displacement of your radius. You have a nursemaid elbow, radial head subluxation, fracture on surgical neck of humerus, injury to axillary nerve, fracture on shaft of humerus, injury to radial nerve, fracture on medial epicondyle, injury to ulnar nerve, supracondylar fracture, injury to anterior interosseous nerve. And then we have this nerve types of nerves and their joint nerve roots. Dorsal scapular nerve, C5. Long thoracic nerve, C5, C6, C7. Nerve to subclavius, C5, C6. Suprascapular, C5, C6. We have those musculocutaneous, C5, C6, C7. Median nerve, C6, C7, C8, and T1. Ulnar nerve, C8, T1. You have this axillary nerve, C5, C6. And you have this radial nerve, C5, C6, C7, C8, T1. That's why radial nerve is also called as the thickest nerve of your brachial plexus. Injury to each nerve, upper trunk injury. Injury to upper trunk causes Erb's palsy, policeman tip deformity, or waiter's stiff deformity. Lower trunk injury, Klumpke's palsy. Okay, and then you have the long thoracic nerve, winging of scapula. Axillary nerve, inability to abduct the arm. Radial nerve, wrist drop. Median nerve at the elbow, ape hand at the wrist, make an O with the thumb. Cannot able to make an O with the thumb and index finger. Ulnar nerve at the elbow, claw hand. Ulnar nerve at the wrist, cannot able to hold the paper between middle and ring fingers. Cannot able to hold the paper between middle and ring fingers. Then you have the artery, subclavian artery, axillary artery, brachial, radial, and ulnar artery, superficial and deep palmar arch. Superficial palmar arch is a continuation of ulnar, deep is a continuation of radial. And then veins follows the arteries courses. And then veins follows the arterial courses. Okay. And apart from that, you are having this lower limb. Speaking about the lower limb. So the lower limb, the first one, same like upper limb, we're going to talk about the bones. So bones, we are having important anatomical landmarks for your hip bone. One is your anterior superior iliac spine, which lies at the level of S1, posterior superior iliac spine, which lies at the level of S2, and the posterior inferior iliac spine, S3. Highest part of your iliac crust is your L4. And apart from that, we have a few named lines in the hip bone, people. One is your Chanting's line, inferior margin of superior pubic ramus to medial margin of femoral neck, it comes down. Nelton line, anterior superior iliac spine to ischial tuberosity, anterior superior iliac spine to ischial tuberosity, and then you have the spectenial line where you see the pubic tubercle to iliopubic eminence, pubic tubercle to iliopubic eminence, and you have the femur. So hip bone, three named lines. What are they? Chanting line, inferior margin of the superior pubic ramus to medial margin of femoral neck. Then you are seeing a Nelton's line, anterior superior iliac spine to ischial tuberosity. Then you have the pubic pectineal line, which is running from pubic tubercle to iliopubic eminence, which is running from pubic tubercle to iliopubic eminence. Okay. So anterior superior iliac spine, ischial tuberosity, pubic tubercle to iliopubic eminence. Apart from that, you have the femur, which is the longest and strongest bone. Angle of femur is 125 in adults and 160 in children. And posterior border is linea aspera. Attachment to this linea aspera are pretty important, or the structures in the linea aspera are important. One, medial lip of linea aspera forms a spiral line, which attaches with the anterior intermuscular septum, while the lateral lip attaches with the gluteal tuberosity, intermediate lip attaches with the posterior intermuscular septum. And apart from that, femur is the most common bone which is fractured in the postmenopausal woman. And apart from that, the fracture of the distal femur causes injury to popliteal artery, and nutrient artery of the femur is your profunda femoris artery. We discussed the nutrient artery table in the back, and these are the important thing you have to remember in the femur. Longest and strongest, and then you have the carrying angle 125 in adults, 160 in children. Most common bone fracture in the postmenopausal. Fracture to the distal femur causes injury to popliteal artery. Fracture to the distal femur causes injury to popliteal artery. And then you have the patella, which is the largest sesamoid bone, and the tendon of quadriceps femoris forms the patella. And then you have the tibia. Most common site for osteomyelitis is your tibia. And the intercondylar area gives attachment to medial meniscus, cruciate ligament, and then lateral meniscus. Medial meniscus, cruciate ligament, and then lateral meniscus. And the nutrient artery is posterior tibial artery. Nutrient artery is posterior tibial artery for the tibia. And for fibula, you're having a pars fracture, lower end of the fibula, with attachment of the medial malleolus, and you may see the rupture of deltoid ligament in the fibula. Okay, same like a bones of lower limb, hip bone. We are having a three named lines. What are they? Chanting's line, which passes from the superior pubic ramus to medial margin of femoral neck. Nelton's line, which passes from anterior superior iliac spine to ischial tuberosity. And then pectineal lines, which forms the posterior tubercle to iliopubic eminence. Then you have the femur. Femur carrying angle of femur in the adults is 125. Children, it is 160. And the attachment of linea aspera, medial lip, spiral line, lateral lip, gluteal tuberosity, intermediate lip, attaches with the posterior intermuscular septum. And the fracture on the distal femur gives rise to injury to popliteal artery. Patella is the largest sesamoid bone, and tibia is the most common site of osteomyelitis. And intercondylar attachment of tibia is medial meniscus, cruciate ligament, and you have this lateral meniscus. Apart from that, fibula, most common site is neck of the fibula fracture. And apart from that, if there is a fracture on the distal end of your fibula, where you may see the medial malleolus fracture or rupture of deltoid fragment. Okay, sorry, a rupture of deltoid ligament, are the things you may see here. Apart from that, tarsal bones, you have the proximal, middle, and distal. Proximal is talus and calcaneus. Proximal is talus and calcaneus, while the middle is navicular and distal is cuneiform and cuboid. So speaking about the tarsal bones, The important condition you have to know is your Mueller-Weiss syndrome, where you see the premature degeneration of your navicular bone. Mueller-Weiss syndrome, where you see the premature degeneration of your navicular bone. Premature degeneration of your navicular bone you may see in this patient. You may see in this patient premature degeneration of a navicular bone, which is present in the Mueller-Weiss syndrome. And apart from that, you have the metatarsal bone. The first metatarsal bone is the strongest one, and the second metatarsal is the longest one. And fracture of metatarsal could result in March fracture. Fracture of the metatarsal could result in the March fracture. Apart from that, you have the sciatic foramen contents. Apart from that, you have the sciatic foramen content. Speaking about the sciatic foramen content, we are having two types of sciatic foramen. One is your greater sciatic, another one is your lesser sciatic. So among that, the foramen contents are the choice of question for the exception people. Foramen contents are the choice of questions for exception type of question. For example, all of the anatomical structure can be passed through the greater sciatic foramen, except, for example, all of the anatomical structures can be passed through the lesser sciatic foramen, except. So these type of exception questions you may be expected in the greater and lesser sciatic foramen content. So we discussed about that. The greater sciatic foramen, the contents are superior and inferior gluteal nerve, which supplies your gluteus maximus, medius, and minimus, and your vessels, superior and inferior gluteal vessels. Apart from the superior and inferior gluteal nerves and vessels, you may also have the longest nerve and thickest nerve in the body, which is your sciatic nerve. And after sciatic nerve, you have the internal pudendal vessel, and then pudendal nerve, nerve to obturator internus, posterior cutaneous nerve of thigh, and nerve to quadratus femoris. So medial and the posterior compartment of the nerves and their smaller nerve and all the respective things may pass through this greater sciatic foramen. For example, what are the contents of your greater sciatic foramen? One is your superior and inferior gluteal nerve and vessels, superior and inferior gluteal nerve and vessels, sciatic nerve, pudendal vessel, pudendal nerve, and nerve to obturator internus, posterior cutaneous nerve of thigh, and nerve to quadratus femoris. And then you have the lesser sciatic foramen, where you see the pudendal nerve, internal pudendal vessel, same nerve to obturator internus, and tendon of obturator internus. Tendon of obturator internus can also be passed through the lesser sciatic foramen. Okay, these are the sciatic foramen contents, people. Then what are the nerve injuries? So the important nerve injuries would be, one is your femoral nerve, where you see the loss of a knee jerk reflex. So femoral nerve supplies your anterior compartment of your thigh, which is your flexion. So flexion of thigh is weakened and extension of leg is lost. And then you have the obturator nerve, which supplies your adductor compartment. So obturator nerve injury causes the inability to do the adduction. And then you have the superior gluteal nerve, which supplies gluteus medius and minimus. Very, very important, people. Superior gluteal nerve supplies medius and minimus, while the inferior gluteal nerve supplies maximus. Okay, superior gluteal nerve supplies medius and minimus, while inferior gluteal nerve supplies maximus. So you have the superior gluteal nerve, where you see the waddling gait and Trendelenburg sign positive. So Trendelenburg sign positive and waddling gait is seen in superior gluteal nerve injury. And then you have this inferior gluteal nerve, where the patient will lean the body trunk backward at a heel strike. So you may have the stepping gait or high stepping gait, you may have it in the inferior gluteal nerve. And apart from that, you have the common peroneal nerve. Fracture on the neck of the fibula could result in common peroneal nerve injury or common fibular nerve injury. Okay, fracture on the neck of the fibula will cause common peroneal nerve injury or common fibular nerve injury. where you may expect to see the foot drop, where you expect to see the foot drop or foot slap. You may see it in the common peroneal nerve injury. Okay, and then you have the tibial nerve, which is at the popliteal fossa. So tibial nerve injury at the popliteal fossa, where you may see the inversion of foot is weakened and the plantar flexion is lost. So tibial nerve, plantar flexion is lost completely. Okay, you have to remember that. And patient cannot able to stand on the shoes. Patient cannot able to stand on the shoes with the tibial nerve injury. Okay, with this we completed the nerves. And then muscular compartments, you have to know. In the thigh, we dissect and we see superiorly, we have the three muscular compartment, anterior compartment, medial compartment, and you have this posterior compartment. So the anterior compartment is also known as the flexor compartment. In the case of your hip, so it flexes your hip, and in the knee, it will do automatically the reverse process. So whatever which is doing its action in the hip, it will do its contraction in the knee. For example, flexor compartment of your hip will flex the hip but extend the knee. And similarly, you have the posterior compartment of the leg, which extends the hip, posterior compartment of your thigh, which extends your hip and causes flexion of your knee. Very good. And medial compartment is the adductor compartment, and then it will supplying nerve would be the obturator nerve. So anterior compartment supplying nerve is your femoral nerve, and your medial compartment supplying nerve is the obturator nerve, and your posterior compartment supplying nerve is a sciatic nerve, which is the thickest nerve in your body, which passes through your greater sciatic foramen. You have to remember that, people. Then, what are the important landmarks that you have to remember in the case of your lower limb? One is your femoral triangle. So femoral triangle, so the borders of your femoral triangle, superior border is your inguinal ligament, which runs from your anterior superior iliac spine to pubic tubercle. Anterior superior iliac spine to pubic tubercle, the superior border runs, and the medial border is formed by the medial border of adductor longus, and the lateral border is formed by the medial border of sartorius. Okay, and sartorius is the longest muscle in your body, and it is also known as the Taylor's muscle. Sartorius is also known as the longest muscle in your body, and it is also known as the Taylor's muscle. Then you have this roof. Roof is formed by fasciolata, and the floor is formed by three muscles: iliopsoas, abductor longus, and pectineus. What are the floor of your femoral canal is formed by? Iliopsoas, pectineus, and adductor longus, while your superior border is formed by inguinal ligament, which run from anterior superior iliac spine to your pubic tubercle, and then you have the medial border formed by medial border of your adductor longus, while the lateral border is formed by the medial border of your sartorius, which is also known as the Taylor's muscle, and which is also a longest muscle in the body, Now, what are the contents of this? What are the contents of this femoral triangle? We used to remember it like a VAN. Femoral nerve, femoral artery, and femoral vein, from the lateral to medial. Femoral nerve, femoral artery, femoral vein. Among that, your femoral artery and femoral vein are covered by femoral sheath. And your femoral sheath is divided into three compartments like this. The lateralmost compartment is occupied by artery, middlemost is occupied by vein, while the innermost is empty, which forms your femoral canal, where you see the draining of your lymph nodes such as Cloquet and Muller. Lymph nodes. Okay, fine. These are the three things you may see it in the case of your femoral canal. Apart from that, you may have the adductor canal or Hunter's canal, where you see the anteromedial border is sartorius, lateral border is vastus medialis, and posterior border is adductor longus and magnus. And then you have the contents of your femoral canal or Hunter's canal: femoral artery, femoral vein, nerve to vastus medialis, and saphenous nerve. saphenous nerves are the contents of your adductor canal. So what are the contents? Femoral artery, femoral vein, nerve to vastus medialis, and saphenous nerve. And saphenous nerve. Then you have the knee joint. Type of the knee joint is hinge joint. Extension of knee is done by ACL. Flexion of knee is done by PCL. And locking of knee is done by quadriceps femoris. And unlocking of knee is done by popliteus. Very, 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 very important MCQ. Unlocking of knee is done by popliteus. Unlocking of knee is done by popliteus. Quite a very, very important MCQ, people. And then you have the ankle joint. Type is a hinge joint. And dorsiflexion is done by deep peroneal nerve. Plantar flexion is done by tibial nerve. Exception is your peroneus longus muscle and brevis muscle, which is supplied by superficial peroneal nerve, which is supplied by your superficial peroneal nerve. Okay. I heard we had a technical glitch. How about now? Can you able to see the screen properly? Now, can you able to see the screen properly, people? We had a small technical glitch. Can you able to see the screen properly now? Can you able to see the screen properly now? We had a small technical glitch. Can you able to see the things properly? Yes. Okay, now the next one is your important nutrient arteries. Speaking about the nutrient arteries, profunda femori artery, which is your femur, and posterior tibial artery is a nutrient artery for your tibia. Peroneal artery is a nutrient artery for fibula, and profunda brachii artery is a nutrient artery for your humerus. Then you have the popliteal fossa. Speaking about the popliteal fossa, we are having the supromedial border as semimembranosus and semitendinosus, and then supralateral border as biceps femoris, and then inframedial and infralateral border as gastrocnemius. And apart from that, the contents are sciatic nerve and popliteal artery and vein, and popliteal nodes and small saphenous vein. Okay, and small saphenous vein. Apart from that, you may have the minor veins like the common fibular vein and tibial vein. Sorry, common fibular nerve and the tibial nerve are the two minor structures. You may see it in the popliteal fossa. But this is all about the lower limb, people. So this is all about the lower limb. So we revise the lower limb for 2 minutes, and then we proceed to the thorax. We revise the lower limb for 2 minutes, and then we proceed to the thorax. So first one, the important landmarks of your hip bone. Anterior superior iliac spine is S1. Posterior inferior superior iliac spine is S2. Posterior inferior iliac spine is S3. Highest part of iliac crest is L4. And then we had a 3 named lines: Chanting's line, Nelleton line, and pectineal line. What is Chanting's line? Inferior margin of superior pubic ramus to medial margin of femoral neck. Medial margin of femoral neck is your Chanting's line. And then you have this Nelleton's line, which is anterior superior iliac spine to ischial tuberosity. And then you have this pectineal line, which is a pubic tubercle to iliopubic eminence. And then you have the femur, which is the longest and the strongest bone. Angle of neck of the femur is 125 in adult and 160 in children. While the posterior border is linea aspera, while the medial lip attaches with the spiral line, along with the anterior intramuscular septum. And a fracture most common in postmenopausal women is your femur, and a fracture on the distal femur will compress as what artery or injury to what artery, which is your popliteal artery. And then you have the patella, which is the largest sesamoid bone and tendon of quadriceps femoris. And tibia is the most common site for osteomyelitis. And you have the nutrient artery for tibia is posterior tibial artery, and nutrient artery for femur is your profunda femoris artery, and nutrient artery for your fibula is your peroneal artery, and humerus, it is your profunda brachii artery. And then type of joint, ankle joint is hinge joint, dorsiflexion is mediated by your deep peroneal, plantar flexion is mediated by your tibial nerve, exception is peroneus longus and brevis, which is innervated by superficial peroneal nerve. And then knee joint, extension of knee is done by anterior cruciate ligament, flexion of knee is done by posterior cruciate ligament, locking quadriceps, unlocking popliteus. ACL extension, PCL flexion, locking quadriceps, and unlocking popliteus. Okay, then you have the femoral triangle. So speaking about the femoral triangle, which is the medial border is found by sartorius, medial border is found by your adductor longus, and lateral border is found by your sartorius, and you have a superior border found by your inguinal ligament. Inguinal ligament. Femoral sheath covers artery and vein, not the femoral nerve. And femoral canal, deep medial portion of your femoral sheath contains a hollow canal, which is your femoral canal, where you see the Cloquet and Muller lymph node, Muller's lymph node. Supromedial border of your popliteal fossa is formed by semimembranosus, and biceps femoris forms the supralateral border. Gastrocnemius medial and lateral head will form the inframedial and infralateral border of your popliteal fossa. Okay, then you have the thorax. So you have the bones of thorax. The first one is your ribs. So ribs, we may classify the ribs based upon the two things. One is your true rib and another one is your false rib. Among the true ribs which are attached to the costal cartilages, so 1 to 7 are your true rib. Among that, 7th one is the longest one. While the false rib, it is 8 to 12. And we classify the ribs based upon the structure as a typical rib and atypical rib. Among the typical ribs are 3 to 9. And the most oblique one is your 9th rib. And atypical ribs are remaining one. Like 3 to 9 means what? 1, 2, 11, and 12. Among that 11 and 12 are your floating rib. Among that 11 and 12 are your floating rib. Okay. And then you have the sternum. So sternum is composed of manubrium plus body plus xiphoid process. And the manubrium and the body is connected by sternal angle of Lewis. So what is the sternal angle of Lewis? The imaginary plane passes between the sternal angle to the T4. Okay, imaginary plane passes between the sternal angle to the T4, which is a junction between your superior and inferior mediastinum. Imaginary line passes between your sternal angle of your Louis to your T4, where you see the junction between superior and inferior mediastinum, and then you see the beginning and the ending of arch of aorta, and then you see the tracheal bifurcation in cadaver, and then you see the SVC PSS fibrous pericardium. SVC PSS fibrous your fibrous pericardium. Then you have the muscles of respiration. Inspiratory and expiratory muscles are there. Inspiratory leading muscles are your diaphragm and intercostal ones, external intercostal muscle, while inspiratory accessory muscles are your sternocleidomastoid, serratus anterior, posterior scalenus, and erector spinae. Serratus anterior, posterior, and serratus anterior and posterior scalene, and then erector spinae, and then you have the pectoralis major and minor. All of them are the accessory, like inspiratory muscle people, while the leading inspiratory are diaphragm and external intercostal one. While the expiratory, leading expiratory is your elastic recoiling of your alveoli and thoracic wall, elastic recoiling of your alveoli and thoracic wall, while the accessory expiratory are latissimus dorsi, internal intercostal muscle, and abdominal muscles. Internal intercostal muscles and abdominal muscle. So they may ask you like either exception, like directly what are the important inspiratory muscle and expiratory muscle, or what are the accessory inspiratory muscles. All of the following are accessory inspiratory muscles, except all of the following are accessory expiratory muscles, except. This might be the questions that may have asked to you. This might be the question that may come to you. Okay, then you have the blood supply of your thorax. Thorax is supplied mainly by two areas. One is your intercostal arteries, another one is your internal thoracic artery. So the internal thoracic artery comes from the subclavian artery, and it continues as a superior epigastric artery by giving a series of branches. So either it gives rise to one branch to the diaphragm as musculophrenic artery, and it may give a three. One is your anterior intercostal artery branch, which is also supplying the rib 7 to 9, and or it may give some perforating branch, or it may give a pericardiophrenik artery. It may give rise to pericardiophrenik artery. So arterial supply of the thorax is done by two major artery. One is your intercostal artery, another one is your internal thoracic artery. So the internal thoracic artery continues down, which is coming from the subclavian artery and continues downwards as a superior epigastric artery. Before that, it may give rise to some few branches. One important branch which supplies your diaphragm is your musculophrenic artery, and apart from that, you have the anterior intercostal artery, perforating artery, and pericardiophrenik artery. Anterior intercostal, perforating, and pericardiophrenik artery. And apart from that, speaking about the intercostal arteries, as we said, we have the anterior and posterior intercostal arteries. So the anterior intercostal arteries comes from two sources. For rib 1 to 6, it comes from the internal mammary artery. And from 7 to 9, it comes from the musculophrenic artery. And 7 to 9, it comes from the musculophrenic artery, which is a branch of internal thoracic artery and continues as a superior epigastric artery. Okay, clear? So internal intercostal arteries are two. One is your anterior and posterior, and the anterior intercostal arteries are received from two sources, from rib 1 to 6 and then from rib 7 to 9. So rib 1 to 6, it may come from the internal mammary artery, and from 7 to 9, it comes from the musculophrenic artery. From the musculophrenic artery. Then you have the posterior intercostal arteries, which comes from superior intercostal artery by 1 to 2 ribs, and descending thoracic artery by descending thoracic aorta by your 3 to 11. So posterior intercostal arteries come from two sources. One is a superior intercostal arteries, which supplies your rib 1 and 2. And then you have the descending thoracic aorta, which comes from 3 to 11, which goes from 3 to 11. And apart from that, you have the venous supply, where you see the anterior intercostal vein and the posterior intercostal vein. Anterior has a similar course as the arteries. They are called as the venous committents. While the posterior one, right side, first rib, first posterior intercostal artery drains into right brachiocephalic vein. Drains into right brachiocephalic vein, while 2 to 4 drains into arch of azygous vein. And 5 to 11 drains into the azygous vein. And 5 to 11 drains into azygous vein. While the left one, first on the left side, on the contrary, first 1 to 4 are supplied by left brachiocephalic vein, while 5 to 8 is superior hemiazygous and 9 to 11 is inferior hemiazygous. So that's the controversy or change here, people. So for the right side, first one is right brachiocephalic, 2 to 4 it is an arch of azygous, and remaining one it is a azygous vein. While left one, 1 to 4 is supplied by your left brachiocephalic, and 5 to 8 is superior hemiazygous, and 9 to 11 is inferior hemiazygous vein. Inferior hemiazygous vein. Nerve supply of your thorax is done by your thoracic spinal nerve. From T1 to T12, it may give rise to your thorax. It may supply your thorax. Okay, this is all about the thorax, people. Blood supply, muscles, and then you have the bones. Now, speaking about the mediastinum, what are the contents of your mediastinum? So, as we said, there is an imaginary plane which is passing between the sternal angle of Lewis to IV disc between T4 and T5. IV disc between T4 and T5, which divides your mediastinum into superior and inferior mediastinum, people. Which divides this imaginary plane will divide your mediastinum into superior and inferior mediastinum, people. So speaking about the superior mediastinum, I used to remember with the mnemonic of vast tet. I used to remember with the mnemonic of vast tet. So what is this vast tet, people? So the V stands for vagus nerve, and A stands for arch of aorta, S stands for superior vena cava, T stands for thymus, another T stands for thoracic duct, esophagus and trachea. Esophagus and trachea. So vagus nerve, arch of aorta, superior vena cava, and the thymus, and then you have the trachea, and then you have the esophagus, and then you have the thoracic duct. Apart from that, you may see the phrenic nerve, left recurrent laryngeal nerve, and the sternohyoid and the sternothyroid muscles. Sternohyoid and sternothyroid muscle. So I used to remember it with the mnemonic of vast TET. The contents of superior mediastinum are vast TET, people. Okay, then you are having the inferior mediastinum. Speaking about the inferior mediastinum, so inferior mediastinum is further divided into three regions from the anterior to posterior. Anterior mediastinum, middle mediastinum, and posterior mediastinum. So anterior mediastinum, which is your sternopericardial ligament, is your anterior mediastinum, and middle mediastinum is your heart and pericardium, ascending aorta, and pulmonary trunk and its branches, SVC and the arch of azygos, and tracheal bifurcation, phrenic nerve, and pericardiophrenik vessels. Phrenic nerve and pericardiophrenik vessels. And posterior mediastinum, where you see the descending aorta, azygos and hemiazygos vein, thoracic duct, esophagus, vagus nerve, and splanchnic nerve. So what are the things you have to remember? Vagus nerve, thoracic duct, esophagus, and descending aorta. All three are in the posterior mediastinum. While heart, ascending aorta, pulmonary trunk, SVC, whatever the structure which is related to your heart, along with the heart, trachea and the phrenic area, which is in the middle. So heart with the trachea and your phrenic nerve, which is present in your middle mediastinum. While whatever the esophagus, thoracic duct, vagus nerve, azygos and hemiazygos vein, and descending aorta, all the structures which has been either emerging out of your aorta or which has been coming out on the posterior aspect of your superior mediastinum, consider it coming from, it belongs to the posterior mediastinum, people. Consider it belongs to the posterior mediastinum. Okay, clear? Now we are moving on to the viscera of your thorax, which is your anatomy of your heart. So anatomy of your heart, we are having the sternocostal surface, which is containing your right atrium, right ventricle, and left auricle are the structures which is forming your sternocostal surface. That is your right atrium, right ventricle, left auricle. And then you have the diaphragm. So diaphragm forms 2/3 of your left ventricle and 1/3 of your right ventricle. Diaphragm forms your 2/3 of your left ventricle and 1/3 of your right ventricle. And then you have the left surface of the heart, which contains left atrium, left ventricle, and left auricle. Left atrium, left ventricle, and left auricle forms your left surface. Then you have a borders. Right border is your right atrium, inferior border is your right ventricle and left ventricle. And then you have the apex, which is a left ventricle, base, which is 2/3 by left atrium and 1/3 by right atrium. 2/3 by left atrium and 1/3 by right atrium. Then you have the extension. So the heart extends from 2nd to 6th costal cartilage and 5th to 8th thoracic cartilage. Costal cartilage, it is 5th to 2nd to, so costal cartilage, it is 2nd to 6th, and thoracic cartilage, it is 5th to 8th. So you have this arterial supply of your heart. So speaking about the arterial supply of your heart, you have the three important arteries which you have to know. Among that, it comes from the two arteries. One is your RCA and another one is your LCA. Okay, right coronary artery and left coronary artery. Okay, and speaking about the important ones, RCA, LCA, and LCX. Left circumflex artery will supply most of the portion. So depending upon what type of infarct, what type of lesions you may able to identify. Okay, so now apart from that, so what is the important thing in the arterial supply of your heart? Remember that cardiac dominance, the determinants of your cardiac dominance is done by a specific artery called as posterior interventricular artery. Posterior interventricular artery. So this posterior interventricular artery determines your cardiac dominance. If it comes from the right coronary artery, then you may have a right cardiac dominance. If it comes from the left coronary artery, then it may have it as a left cardiac dominance. Okay, either a right or a left cardiac dominance you may see, that is determined by the specific artery. What artery it is? It is your, what artery it is? It is your posterior interventricular artery. Posterior interventricular artery. And apart from that, all part of your conducting system are supplied by right coronary artery, except your RBB, which is supplied by your left coronary artery. Except your RCA, which is RBB, right bundle branch, which is supplied by your left coronary artery, which is supplied by your left coronary artery. And then you have this diaphragm opening, IVC opening on T8, esophageal opening on T10, aortic opening on T12. Aortic opening on T12. Then you have the anatomy of lungs. The highlights of the anatomy of lungs are right lung contains 3 lobes and 2 fissures, while the left lung contains 2 lobes with 1 fissure. And you may have the cardiac notch in the left lung. And apart from that, you may have the bronchopulmonary segment. So speaking of a bronchopulmonary segment, you may have a lot of bronchopulmonary segment, and lingula is seen in the left lung, while lingula is not seen in the right lung. While lingula is not seen in the right lung. Then you have the carina. Patient is made to lie on his left side. Secretion from the right bronchial tree will flow towards the carina due to the effect of gravity. This is the importance of carina, people. What is the importance of carina? Whenever the patient is made to lie on his left side, secretion from the left bronchial tree will flow towards the carina due to the effect of gravity. Due to the effect of gravity. And then you have the segments of lung. Right lung contains a bronchopulmonary segment. Upper lung, upper area, you may have the apical, anterior and posterior. Middle one contains a medial and lateral. Lower one contains apical, anterior basal, posterior basal, medial basal and lateral basal are the 4 areas you may see it in the lower one. So apart from that left lung, upper one, apical, anterior and posterior, while the middle one, superior and inferior lingulas, while the lower one, apical, anterior basal, posterior basal and lateral basal. Apical, anterior basal, posterior basal and lateral basal are the one which you may see it in the left lung. These are the segments of your lung. These are the segments of your lung. Apart from the esophagus, length of esophagus is 25 centimeter and extends from pharynx to your stomach, and diaphragm opening is seen in T10, and a crossing of left bronchus in T6, and a crossing of arch of aorta in T4, and you have the cricopharyngeus part of your inferior constrictor is seen in C6, sorry. And then you have a blood supply. Blood supply of your esophagus is done by inferior thyroid artery, descending aorta, bronchial artery, left inferior phrenic artery, and veins is a venous committant. So it follows the arterial course. It follows the arterial course. Apart from the abdomen and pelvis are there, you have the named fascias in your anterior abdominal wall. Camphor fascia, which is a fascia of your anterior abdominal wall. Scarpas is a deep fascia, while camphor is a superficial fascia. Apart from that, you have a perineum, you have a Colles fascia, which is a deep membranous layer of your perineum, and Buck's fascia, which is a superficial fascia of your penis, and Gerota's fascia, anterior layer of your perineal fascia, and Zuckerkandl, posterior layer. So perirenal fascia, anterior layer is Gerota, while posterior layer is fascia of Zuckerkandl. Okay, then you are having a fascia of Denon-Villiers, which is a rectovesical fascia or rectovesical septum in your female and rectoprostatic septum in your male. So Denon-Villiers is rectovesical in a female and rectoprostate in male, and Zuckerkandl, posterior perirenal, Gerota, anterior perirenal, and superficial fascia of penis is Buck's fascia, and you have the deep membranous fascia of perineum is Colles, while the anterior abdominal wall it is Scarpa, and it is a superficial layer of your anterior abdominal wall is your Camper's fascia. And then you have the inguinal canal. So inguinal canal, we have the anterior wall, posterior wall, and then you have the roof and floor. So anterior wall is formed by skin, superficial fascia, and external oblique aponeurosis. Posterior wall, fascia transversalis, while roof, internal oblique and transverse abdominis, while floor, inguinal ligament and lacunar ligament. Inguinal ligament and lacunar ligament forms the floor of your inguinal canal. Okay, then content. The contents of your inguinal canal are spermatic cord in male and round ligament in female. Apart from that, it may also contain the ilioinguinal nerve. So what are the contents? So what are the contents of your inguinal canal, which is very, very important? In the male, ilioinguinal nerve along with the spermatic cord, and in the female, spermatic cord is replaced by your round ligament. Spermatic cord is replaced by the round ligament. Apart from that, you may have the important triangles of your abdomen. Speaking about the important triangles of your abdomen, first triangle is your Hasselbalch's triangle. The anterior or the medial border is formed by the lateral border of your rectus abdominis muscle. Medial border is formed by the lateral border of your rectus abdominis muscle, while the inferior border is formed by inguinal ligament, while the lateral border is formed by inferior epigastric artery. While the lateral border is formed by inferior epigastric artery. And then you have the triangle of doom, apex, and then you have the medial border, lateral border, and inferior border. Lateral border forms the gonadal vessels, while the medial border forms the ductus deferens, while the inferior border forms the peritoneal reflection. Okay, peritoneal reflection. Then you have the triangle of pain, where you may see the medial as a gonadal wall and iliopubic tract as a lateral, and the contents are femoral branch of your genitofemoral nerve and lateral cutaneous nerve of your thigh. Lateral cutaneous nerve of your thigh. Then you have a Passaro's triangle. You have the lateral border and apex, and then inferior part. Apex formed by junction of common bile duct and cystic duct, while the left lateral part is formed by junction between neck and body of pancreas, while the inferior part is formed by junction of second and third part of duodenum. Junction of second and third part of duodenum forms the Passaro's triangle. Then you have the branches of celiac trunk. So the very, very important MCQ is this: your branches of your celiac trunk. One is your common hepatic artery, splenic artery, and left gastric artery. Common hepatic artery, splenic artery, and left gastric artery are the three major branches coming from your celiac trunk. Apart from that, you have the left inferior diaphragmatic artery and you have the common trunk, but those are all the minor branches. The major branches of your celiac trunk are splenic artery, left gastric artery, and common hepatic artery. Splenic artery, left gastric artery, and common hepatic artery. Okay, then now speaking about it, we have the important GI organs and the ligaments. So spleen is made up of red pulp and white pulp, while the red pulp is a vascular one and the white pulp contains a lymphoid aggregations. Then you have adrenal gland, a pair of triangular shaped glands, each of 2 inches long and 1 inch wide, which may sit on the top of the kidneys. You may see here. So this adrenal gland contains adrenal cortex and medulla. You may see that there is a variety of hormones which has been secreted from the adrenal cortex. The 3 layers of adrenal cortex are zona glomerulosa, fasciculata, and reticularis, which secretes mineralocorticoid, glucocorticoid, and your sex hormones. Your sex hormone. Apart from that, you are having the ligaments of your abdomen. So important ligaments are: number 1, falciform ligament, which is running from the liver to your anterior abdominal wall, and this falciform ligament is a derivative of your ventral mesentery. Okay, which is a derivative of your ventral mesentery. Okay, and then you have this hepatoduodenal ligament, which is a liver to your duodenum, right? The hepatoduodenal, and it contains a portal triad, people. Each hepatoduodenal ligament contains portal triad, where you may see the what is a portal triad? A artery, a vein, and a bile duct. All 3 combinedly forming a portal triad. A artery is your proper hepatic artery, and a vein is your portal vein, and a bile duct is your common bile duct. All 3 exits as a portal triad. Okay. What type of maneuver you may use to compress this ligament? which is a Pringle maneuver. During the Pringle maneuver, you may compress this hepatoduodenal ligament, which is placed on your omental foramen to control your bleeding. Okay, to control the bleeding. Apart from that, gastrohepatic ligament. So gastro to hepatic, lesser curvature of stomach to liver, and contain gastric vessels. Contain gastric vessels. And then you have a gastrocolic ligament, which is like a stomach to your transverse colon, and gastrosplenic ligament, which is your stomach to your spleen. And then you have a splenorenal ligament, which is your spleen to your kidney, or posterior abdominal wall. You may see the spleen to your kidney. And apart from that, these are the important ligaments of your liver. These are the important ligaments of your liver. Okay, fine. We know all the important ligaments of your abdomen. The main one is your hepatoduodenal ligament, which is your portal triad, which may gives rise to the portal triad. Okay. Apart from that, you may have the head and neck. The next area we are going to talk about is your head and neck. And speaking about this head and neck, we divide the head and neck into three regions, namely anterior cranial fossa, and then we have it in the middle cranial fossa. And then we have this posterior cranial fossa. And then we have this posterior cranial fossa. Let me put this. Delete. And I'll add one more thing, which is your posterior cranial fossa. Well, those were the anterior cranial fossa, middle cranial fossa, and the posterior cranial fossa. So anterior cranial fossa, we are having a one important structure. That structure is so called as cribriform plate. And from the cribriform plate, you may have the olfactory foramina. And from the olfactory foramina, you may have the olfactory nerve, which is emerging through it. And then you have this middle cranial fossa. And the middle cranial fossa, we used to remember with standing room only for seniors. Okay, standing room only for seniors. So S stands for superior orbital fissure. So the S stands for superior orbital fissure, and standing room. R stands for foramen rotundum. And after the foramen rotundum, standing room for seniors. So standing room only for seniors. So O stands for foramen ovale. Below the foramen ovale, and then from foramen ovale, you have the foramen spinosum. Let me erase all the content here so that you can able to remember it. So this is a foramen, this is a superior orbital fissure, and you have this optic foramen and foramen rotundum and foramen ovale, and foramen below the foramen ovale, you have the foramen spinosum. So standing room for only for seniors. Okay, now superior orbital fissure. So speaking about the superior orbital fissure, what are the nerves which may come? 3, 4, 6, and then you have the 5 first part. Okay, and then you have the 5 first part. So you may have the exit of 3, 4, CN, 3, 4, 6, and then you have the 5-1, all of them are coming through the superior orbital fissure or near to the superior orbital fissure. And in the optic canal or optic foramen, you have this CN2 and ophthalmic artery. Ophthalmic artery, which is coming through that. Okay, then you have the foramen rotundum, where you may see the cranial nerve 5, and the foramen ovale, you may see the cranial nerve 5, but 5-2 and 5-3 will be there. And apart from that, foramen spinosum, where you see the middle meningeal artery, your MMA, middle meningeal artery will be protruding through the foramen spinosum. Okay, foramen spinosum. And then you have this foramen, you have this posterior cranial fossa. Important posterior cranial fossa contents are, one is your internal auditory meatus, internal acoustic meatus, I, J, jugular foramen, and then you have this hypoglossal canal. Behind that, you have this hypoglossal canal, and after the hypoglossal canal, you may have this foramen magnum. Hypoglossal canal, you may have this foramen magnum. So what are the structures that may comes through this internal acoustic meatus, people? What are the structures that may come through this internal acoustic meatus or internal auditory acoustic meatus or internal auditory meatus, where you may see the cranial nerves 7 and 8, people? What nerves are emerging through that? Cranial nerve 7 and 8 are protruding through that. Cranial nerves 7 and 8. 7 and 8 are protruding through that. And after that internal acoustic meatus, you have the jugular foramen, where you see the jugular vein, and the cranial nerve 9 to 11. 9, 10 and 11 will pass through the jugular foramen. Then you have the hypoglossal canal, where you may see the cranial nerve 12. And then you have the foramen magnum, where you may see the brainstem, and then you have the spinal root of cranial nerve 11, and then you have the vertebral arteries, Okay, so brainstem, spinal root of cranial nerve 11, and then vertebral arteries. So here, olfactory foramen from the cribriform plate, where you see the olfactory nerve in the anterior cranial fossa. So anterior cranial fossa contains only one dominant structure, which is your cribriform plate. Among that olfactory foramen, you may see the olfactory nerve. And apart from that, middle cranial fossa, you may have a 5 to 6 structures. Only the standing room, only for seniors, is a mnemonic. Optic canal, you may see the cranial nerve 2, and you may see the ophthalmic artery, and then you have the superior orbital fissure, that is a senior, so standing room only for seniors. Standing, S stands for superior orbital fissure, which is cranial nerve 3, 4, 6, and 5, 1. And room, foramen rotundum, which is a cranial nerve 5, 2. Foramen ovale, cranial nerve 5, 3. Foramen spinosum, cranial nerve, middle meningeal artery is the structure which passes through. Okay, then you have the posterior cranial fossa, where you may see 4 structures: internal acoustic meatus, jugular foramen, hypoglossal canal, and you have this foramen magnum. Internal acoustic meatus 7 and 8. Jugular foramen, you may see cranial nerve 9, 10, 11, and jugular vein. And then for the foramen magnum, brainstem, spinal root of cranial nerve 11, and vertebral artery. And then you have this hypoglossal canal, where you see the hypoglossal nerve emerging out of it. So these are the cranial nerves which emerges from the brainstem. From the midbrain, you see the cranial nerve 3 and 4, pons 5, 6, and 7, and 7 and 8. Even 8 we can consider it from the pons, while from 9 to 12 it is solely from the medulla oblongata. 9 to 12 it may solely from medulla oblongata. Okay, then apart from that, you have the superior orbital fissure contents. So speaking about the superior orbital fissure content, there are a lot. Among that, the trochlear nerve, frontal nerve, lacrimal nerve, trochlear nerve, frontal nerve, and lacrimal nerve are the important ones you have to remember. And the single most structure is your optic nerve, which you don't need to worry about it. And apart from that, you have the sphenoid bone and the circle of Willis. Speaking about that, circle of Willis is pretty important, people. Speaking about that, the circle of Willis is pretty important that you have to know. So circle of Willis. So it is an arterial circle which supplies your brain, So speaking about the arterial circle which is supplying from your brain, we used to call that as anterior circulation and posterior circulation. We can divide the circle of Willis into anterior and posterior circulation. So from the posterior, whatever below the posterior cerebral artery is forming a posterior circulation, whatever the anterior to your or above your posterior cerebral artery, which forms your anterior circulation. So posterior circulation is below your posterior cerebral artery, while your anterior circulation is in front of your anterior cerebral artery. So speaking about this posterior cerebral artery, speaking about this posterior circulation, from the down we can say that we are having the vertebral artery. We are having this vertebral artery which is coming from both sides, from the first part of your subclavian artery, and they can give rise to either the anterior spinal artery. It can give rise to the anterior spinal artery, and they combine into one single artery called as basilar artery, people. One single artery called as basilar artery. Okay, two vertebral artery combined together and form the basilar artery. And this basilar artery will give rise to three important branches. With the basilar artery gives rise to three important branches. One is your anterior inferior cerebellar artery and superior cerebellar artery. Other two arteries you may give rise to, and it goes to the cerebellum. Because in a brain, if you see, consider this is a diagram of your brain, and if you are dissecting here, you may see that there is a pons, and behind the pons there is a cerebellum, and then you have the medulla oblongata. So circle of Willis coming up from here, vertebral artery combined to form a basilar artery. So it gives rise to three branches, two posteriorly and one anteriorly. So what are the two posterior one? Superior inferior cerebellar and anterior inferior cerebellar, and you have the anterior cerebellar artery. Superior and inferior cerebellar artery, and among that inferior cerebellar artery you may see the anterior inferior cerebellar artery. So the two posterior branches are, one is your anterior inferior cerebellar and another one is your superior cerebellar, and between that it may give rise to numerous branches anteriorly, which is your pontine artery. I'm going to highlight here, which gives rise to the pontine branches, people, which gives rise to the pontine branches. Okay, fine. And then it is continuing upward as a posterior cerebral artery and splits into two, where it gets attached with the posterior communicating artery, and the posterior communicating artery is communicating with the internal carotid artery. You know that it is coming from the internal carotid artery, and this internal carotid artery technically will give rise to anterior, middle, and anterior and middle cerebral artery, and in between that internal carotid artery will give rise to anterior and middle cerebral artery. This is the anterior and this is the middle cerebral artery. Okay, so let me draw the circle of Willis. We have this vertebral artery from the two sides, which continues upwards as a basilar artery, and before it is continuing upward, which is combining as a basilar artery, it gives rise to the posterior inferior cerebellar artery, and then after forming the basilar artery, it gives rise to three branches, two posterior branches and few anterior branches. What are the two? Superior cerebellar artery and anterior inferior cerebellar artery. And here it may give rise to pontine branches, and then here it may give rise to pontine branches. Remember, all these are cerebellar. Okay, now the superior, this basilar artery will goes upwards. This basilar artery will goes upwards and splits into posterior cerebral artery, which is PCA. Splits into posterior cerebral artery. And after this posterior cerebral artery will give rise to communicating branch, and this communicating branch will combine with the internal carotid artery. It is combining with internal carotid artery, and then this internal carotid artery goes lateral as MCA and gives rise to ACA also, anterior cerebral artery and middle cerebral artery. Middle cerebral artery goes laterally, while the anterior cerebral artery